AETCM, the Emergency Medicine Channel. Today we're discussing a case of an elderly female who presented to our ER with complaints of productive cough and following which she had 2-day history of reduced response. Sir, there was this 69-year-old female patient who approximately for about 4 to 5 days had history of on and off fever along with that cough, and then for the last 2 days she had reduced response, following which she was taken to the hospital where she was given initial management. That in view of hypotension, she was brought to our hospital for further management. So in our initial 10-second assessment, patient had a GCS, or rather in the initial 10-second assessment, patient was only responding to the verbal commands. And in our primary survey, airway was compromised as the patient had reduced response to. Along with this, she could not talk in one full complete sentence. But there was no increased secretions, no anatomical deformities, no hoarseness of voice tried or noted. Breathing, so at this point in time, all we did was we put her in a proper position. Then breathing wise, she was tachypneic and obvious respiratory distress with a respiratory rate of 36 cycles per minute. And she only had saturation of about 88% on room air. So we placed her on NRBM and we were simultaneously preparing her for a positive pressure ventilation, preferably in RSI, because she didn't look like she was going to cooperate with our BiPAP machine. So with this, we moved on to the circulation bit and we found her to be tachycardic but with regular pulse. Heart rate was about 123 beats per minute, but BP was not recordable. And all peripheral pulses were feeble and warm. So at this time, we realized that the patient was in shock. The cause of the shock, we had to further evaluate for it. Disability wise, she had a GCS of E4, V3, M5, totaling up to 12 on 50. So pupils, however, were bilaterally symmetrically reactive to light. So exposure wise, she was running a temperature of 100.3 degree Fahrenheit with a blood sugar level of 260.
100.3 or 103?
100.3 degree Fahrenheit with a blood sugar level of 267 milligram per deciliter. So far from our primary survey, we found that the patient was in shock, so we immediately placed 2 large bore IV cannula and we just started her on a fluid challenge.
So how do you diagnose that patient is in shock?
One, signs of instability we'll have to see, sir. Altered sensorium, any ongoing chest pain with or signs of heart failure, or if the patient is in hypotension, these could mean patient is in shock. In this case, patient's BP was not recordable and she also had altered sensorium. These 2 parameters were enough to regard her as an unstable patient. So in a quick examination, we also found her to have bilateral pedal edema was there, and on auscultation she also had crepitations. So we were also suspecting heart failure, which is why we did not push in fluids, but we started her on fluid challenge. Wherein normally when we have to give boluses, we give it as 30 ml per kg. And then we give IV boluses. But we're giving IV fluid challenge, meaning we don't push in rapid fluid, we only give 500 ml to 1 liter. And if patient condition worsens, it means she's in fluid overload state. So we don't really push in. If the patient goes into cardiogenic shock or something, then we'll have to start on early inotropes over pushing the patient on fluids.
Now, other tests to know whether the patient is fluid overloaded or fluid depleted with shock?
So there are dynamic and static parameters. In static parameters, we can check for bilateral pedal pitting edema or any signs of heart failure which can denote cardiogenic shock. And also we can look for IVC, but then and urine output is also there. And there is something called as a tilt test, where passive leg relaxing test, wherein we tilt the patient in supine position and see if the systolic blood pressure increases. Any increase in systolic blood pressure of more than 20, meaning to say that patient was hypovolemic. So because we tilted the patient, preload increased, and following which the
SBP is an indicator to give more
fluids. So but this patient was in distress, so we could not do that leg raising test. And she had signs of heart failure, which is why we did not push in IV fluids at this juncture at least. And then with this primary survey, so far what we have done, the interventions are, we put her on NRBM, high flow oxygen, simultaneously we prepared her for an RSI, and we also started her on IV fluids. keeping in mind early initiation for vasopressor agents if need be. So with this, our agents to primary survey, we took in ABG as patient had obvious respiratory distress, and we found that the patient had a mixed disorder with a pH of 6.9 and PCO2 was 86. PO2, however, was very low, 38, and bicarbonate was 16 with a lactate of 8.8. So patient had respiratory acidosis with hypoxemia along with this metabolic acidosis secondary to lactate. So it was lactic acidosis.
So why lactate is increased? What are the reasons for increased lactate?
In this case, one, it can be because of hypoperfusion as the patient had not recordable BP, and second, it could be secondary to even hypoxia.
Both are possible.
Both are possible. So with this lactate 8.8, we knew, and because patient was running a temperature also, we gave a paracetamol 1 gram IV, and we were now thinking in terms of septic shock, although the source of infection was yet to be determined. So with this, we did a point of care CBC CRP which showed a total counts of 23,800 and a CRP was more than 180. Neutrophil predominant, neutrophils was 90.3 and lymphocytes were 10.2. Then apart from this, we took an ECG to rule out any arrhythmias, any signs of myocarditis. All we found was the patient had sinus tachycardia, no significant STT changes because sepsis itself can trigger MI or arrhythmia, or patient can have myocarditis, which could have led to this thing. But patient only had sinus tachycardia, which could be secondary to the hyperperfusion as a compensatory mechanism, and also because patient was running temperature. So then our next thing to deal with was GRBs. Blood sugar levels was more than 250, and ABG also showed acidosis. So we had to rule out DKA. So according to the criteria for diabetic ketoacidosis, pH should be less than 7.3, with bicarbonate less than 18, rather 15, and PCO2 should be not PCO2. Ketones may or may not be positive, and blood sugar levels should be more than 250.
Ketones has to be positive.
Then
ketone has to be positive. Sugar may be normal or high. Sometimes it can be euglycemic ketones. But ketone body has to be positive.
Then blood sugar levels have to be more than 250 milligram per deciliter. So all of these parameters fit in, except that serum ketones had to be sent, which we did, and since the patient was already in sepsis, so we started the patient on insulin infusion at the rate of 0.21 international unit per kg per hour. So then we did a bedside IVC check, which was dilated, not collapsible, volume overload, so it was not collapsible, and distended with 1.5 centimeter. And bedside also lung ultrasound showed lung sliding present on bilateral side with no signs of effusion, but left lower zone and posterior regions had collapse features and consolidation. The tissue-like features were found on ultrasound. So with this, we knew that it could possibly be a lower respiratory tract infection, or it could be secondary to the aspiration because of reduced response. So we started the management. Now moving on to the sample part of the history. Signs and symptoms was one, she had a 4 to 5 days history of productive cough with on and off fever and intermittent chest pain, not radiating, more the lines of pleuritic in character. And apart from this, she had no signs of hemoptysis, but very low grade fever, like 100 degree Fahrenheit, around that temperature. And then but then she was just on an OPD basis managed. But for the last 2 days, she did not have any good appetite, and she had increased weakness and fatigue. And then she slowly started to have reduced response. That's when they took her to the hospital and found her have hypertension. So these were the events that led up to it. She was not known to have any drug allergy, and medication, she was known to have diabetes, but she was not very compliant with her medication history. So she only used to take an OHA on an on and off basis. And then apart from that, non-relevant background was that she had varicose veins. So this was her past history. And then, so in our general physical examination, she was a moderately built patient with a BMI of 21.3 kg per meter square. and she had raised JVP in her clinical examination with bilateral pitting edema, pedal edema, but there was no signs of any pallidus sinuses or lymphadenopathy, and she looked like she was in obvious respiratory distress, agitated. And moving on to her systemic examination, we found her to have bilateral crepitations, predominantly on the right side and in the posterior lung fields. Trachea was central, air entry was bilaterally equal with respiratory distress, so she was tachypneic also, but there was no distended neck veins or any discoloration of the chest noted. So, other systemic examination, however, were within normal limits. Um, like abdominal findings on thing, and CNS examination could not be done. Circulation examination wise, she had all peripheral pulses to be feeble, and we could not hear much of murmurs or anything of that sort. Well, because the heart rate was too high for us to figure out any auscultatory findings. So with this, our conclusion was that the patient had an infection, possibly an aspiration pneumonia versus any lower respiratory tract infection, which led to sepsis, septic shock, possible heart failure also. So management wise was according to the surviving sepsis guidelines of the year 2021. So with this, we started the patient on fluids. Upon reassessment, patient continued to have not recordable BP. So we started her on first vasopressor agent, that was noradrenaline. The idea was
what else can vasopressor is correct. That is the ideal choice in emergency. What else may be useful in a patient who is saying volume overload with hypotension?
Like vasopressin.
Other than vasopressor, vasopressor is a very good choice. Albumin. Most of these sepsis patients, what happens is vascular leak and hypoalbuminemia will be there. Because of cost, we are not able to give albumin initially. But once you know that volume is overloaded and the patient is having hypertension, albumin will be a better choice to correct most of the things. But like you told, the ideal situation in a normal ER setting, we have to start vasopressors like noradrenaline.
So we started her on noradrenaline. The idea was to attain a target MAP of more than 65 millimeter mercury. So this is also inconsistent with the guidelines.
According to guidelines, what is the definition of septic shock?
Basically, the patient should have a source of infection with an end organ damage. Shock is when the patient has hemodynamic instability. So,
according to this definition, surveying sepsis guideline,
end organ damage with source of
tissue
infection
hypoperfusion should be there.
Should be there. Then you need to start 30 ml per kg body weight. Even then the map is not maintained, so that you are
to start a vasopressor.
That is the definition of
shock.
Septic shock according to your guidelines. Okay. Otherwise, what we understand in normal practice, somebody is not improving with your saline infusion, then it is a septic shock. But according to the guidelines given in the book, we have to start a noradrenaline infusion to maintain the map above the range of 65.
So our management, apart from this, we collected the blood for the routine lab investigations and also collected it for blood culture, including urine culture was sent. Then blood lactate levels were
taken. How do you collect
taken.
Blood culture in sepsis?
So we have to take
what
it
is
from.
Importance? How many patients can have a positive blood culture in sepsis?
Very less. So very exact number.
30% can be, maximum is 30% in most of the settings. And that itself, there is a high chance of contamination when you are taking in a busy emergency room. And we need to take a lot of blood samples. We have to take 2 sets of blood culture. Each set should have 2 aerobic and 1 anaerobic. Like that, 4 or 5 samples we have to take. Most of the time in our settings, it is not possible. Just take 1 sample or 2 samples and start antibiotic. Because blood culture is also costly in our country. So we have to take very minimal sampling, and in that aerobic and anaerobic not required in our country, because you are going to treat most of the antibiotic what you are going to give, that even covers the anaerobic infection. So if you are suspecting strongly anaerobic infection like intraabdominal infection or aspiration pneumonia, then only that is required. Otherwise, anaerobic culture may not be very useful in a routine setup. Okay, but in ICU patient is having pyrexia of unknown origin, you want to make out what is the diagnosis, then it is okay.
So then urine output we had to monitor, which is why under aseptic precautions we catheterize the patient. So we give 3 and take 3. Check the blood lactate levels, urine output, then blood
What is the
culture, IV
advisable urine output
antibiotics.
in a patient who is
0.5 to 1
0.5
ml per kg per hour.
Okay.
So then with this IV antibiotics, if at all we're strongly suspecting sepsis patient, then ideally it has to be empiric broad spectrum antibiotics have to be started within 1 hour, but maximum by within 3 hours.
Oh.
These are the guidelines. So only one broad spectrum agent, if we are able to cover, that will be enough until the culture reports come in. Previously, 2 gram negative coverage or MRSA, all that is not recommended these days. So with this, this will be the antibiotic coverage.
So what antibiotic was started for this patient?
For this patient, we started on carbapenems.
Okay.
So we started on meropenem. Then
1 gram.
1 gram IV TID.
Creatinine?
Creatinine was normal. The patient had no signs of acute kidney injury.
Okay.
So ideally, if at all kidney is damaged, then according to the creatinine, first dose has to be given completely, following which we'll have to titrate it according to the creatinine clearance.
Okay.
So the other part of the management again went with airway, breathing and circulation. So we had to first secure the patient's airway, which is why we went ahead with an RSI, wherein we started the patient on she was already on NRBM, so pre-oxygenation was dealt with. Then for our agents, we used fentanyl as a pre-medication drug, which was both anxiolytic and analgesic, and was given at 1 microgram per kg dose, and then etomidate was used as a reduction with 0.3 milligram per kg, and rocuronium was a paralytic agent at 0.9 milligram per kg. So these were our medications, and we intubated the patient. Position was checked with 5-point auscultation, and ETCO2 was also taken, which was
Have you
30.
taken an X-ray before?
Yes, sir. Portable X-ray was taken, and then following the placement of the tube, repeat X-ray was also taken.
Why it is required?
One to check for the position of the tube, because single lung ventilation is also
That is
possible.
most important. Anyway, when you are auscultating, you get an idea where is the tube. But it is always better to document that you are taking an X-ray and keep both sides are equally when you need.
So then other X-ray findings were minimal pleural effusion was seen on the left side along with collapse consolidation, and bilaterally heterogeneous infiltrates were also noted. So patient had lower respiratory tract infection, possibly along with that aspiration, because there was a consolidation bit in the lung field. So the next day we secured the airway, and then our ventilator settings was maintained, like tidal volume had to be 6 to 8 ml per kg, with the pressure, inspiratory pressure was up to 30 centimeter water, and then FiO2 was titrated in order to maintain SpO2 more than 95%.
Was there any hypotension during intubation?
She was already having not recordable BP. So she was already put on NORAD. Everything happened parallelly. So following intubation on about an hour later, when upon reassessment, patient had blood pressure. 80/40 was her blood pressure, and then it was titrated to maintain MAP of more than 65 mmHg. Then urine output target was 0.5 milligram ml per kg per hour, and then insulin infusion was also initiated. That to maintain target glucose of more than up to 180 milligram per deciliter. So since she was also mechanically ventilated, every 4th hourly we checked blood sugar levels. Then laboratory investigation wise, inflammatory markers were elevated. Even procal was more than 10.
But this patient had volume overload. How do you clear the ketone bodies from the body? See, normally we deal with the decay means when we are reading, it will be dehydrated. It will be very straightforward decay. Patient will be dehydrated. You can give a lot of fluids. But in this patient, how do you are going to deal with the ketone bodies? We have to remove it from the body. because it's already produced. What do you
Give
do?
fluids and Lasix.
You have to give, first you have to
Diuretic.
start Lasix infusion and remove fluids and remove fluids from the body, then add IV infusion so that continuous urination will be there. Patient ketone bodies will go out. Otherwise, ketone bodies will not be removed from the metabolism.
And then other parameters.
So normally, according to the guidelines, DKA means there are three components: high blood sugar, ketone bodies positive, dehydration. So unfortunately, many patients who is having renal failure, cardiac failure, they can have still volume overload. So that we have to be very careful. Some patients, as per books, we cannot give. As per like guidelines, we have to give fluids, but we cannot give fluids in this type of patient. So we have to be very careful.
Then other lab investigation wise, serum electrolyte sodium was 130.9, but patient had hyperkalemia. It was about 6.5.
Okay.
But then we did not bother much about it because we had already started the patient on Lasix infusion and insulin infusion,
Okay.
and every fourth hourly we kept checking the serum electrolytes. But cardiac enzymes were also elevated with the pro BNP was 32,000.
Okay.
So we had started the patient on Lasix infusion. So apart from that, mechanical ventilation.
What else you can add? This patient is having hypotension, this patient is having high BNP, this patient is having volume overload. What else you can add to improve the internal circulation? You can increase the kidney perfusion.
You can start anatropic from dobutamine.
Dobutamine has to be so. Once you start noradrenaline, it will increase the BP. Then you have to start dobutamine because that only will improve the situation. Lactate indicates what? High lactate indicates
Tissue hypoperfusion.
tissue hypoperfusion. That is the main problem. Here the patient is having volume overload in the venous compartment, but the arterial compartment nothing is there. So we have to pump more blood. So then we have to start and with noradrenaline we have to start dobutamine. Okay. Then the patient will improve. Maybe the reason for cardiac failure may be acute sepsis-induced myocarditis.
Then on our repeat laboratory investigations showed acute liver failure along with not liver failure, liver injury with SGOT was 400 some 400 range and SGPT was in 380 range with and with creatinine being 3.65.
Okay.
So ischemic hepatitis possible.
Normally ischemic hepatitis, it can be an early phase of ischemic hepatitis. Normally severe ischemia can produce SGOTs between thousands. But in early ischemia, it can be mildly elevated, and once you give fluids and other things, it can reverse backwards.
And repeat potassium came down. But then patient had worsening RFT, which is why we had to also initiate the patient on hemodialysis. So patient underwent 2 sessions of hemodialysis. And after about 3 days of mechanical ventilation, she was extubated.
Okay.
Then ABG improved, acidosis revolved. Then we were able to wean off inotropes. And then we even stopped insulin infusion, Lasix infusion, all of that. So in due course of time, patient improved.
Okay.
So now we are focusing more on early mobilization and rehabilitation for the patient.
Again, in renal failure, ketone bodies removal will be a problem. There are 2 types of renal failure. One is non-selective, like the patient can have more urination with renal failure. There is no decreased urine output. The other one is patient that is having decreased urine output. If the patient is having more urine output and renal failure, it is very difficult to monitor the urine ketones. Continuously, they can have ketone bodies positive. Whereas there is patients who is having renal failure with ketoacidosis, then you will not be able to remove the ketone bodies in a usual method. Then, like you told, dialysis is the only way. Otherwise, patient will never improve. Their ketoacidosis will last long.
In her first echo, she had severe LV with global hypokinesia. Ejection fraction was only up to 35 to 40%. But after she improved, a repeat echo also showed improvement in the LV function, and ejection fraction increased to up to 50%. Then chest X-ray, repeated serial X-rays were taken, and it showed clearing of the infiltrates and the consolidatory patch. So overall, patient stay in the hospital improved. The other thing we had to do was to check the nourishment because she was on RT feed, and then bubble bladder movements, and then also DVT prophylaxis.
Okay.
So ideally, a low molecular weight heparin would be a preferred DVT pharmacological prophylactic agent.
What
But
type of
because
hypercoagulable state it is?
DIC, like
Hypercoagulable state.
State.
Decay is hypercoagulable state. What type of hypercoagulable state it is? Hypercoagulability is due to decreased vascular content. Blood will become highly viscous and water is removed. But here you are dealing with anyway you have to start heparin, that is a different issue. But here you are dealing with a patient who is having decay but volume outload. It's not like a textbook case. It's a slightly different case. But even then, DVT prophylaxis has to be given because patient is having chronic diabetic nephropathy. He can have antithrombin 3 deficiency. Okay. So we have to give any patient admitted in ICU, we have to give heparin prophylaxis. Heparin or low molecular weight.
Ideally, it is no molecular weight heparin, sir, but because this patient had kidney injury, we go
Ideally
on
means
fraction.
what?
Like
Not
if the
patients.
patient who does not have any kidney injury or thrombocytopenia,
There is nothing like that. You can give regular heparin or low molecular weight heparin. Low molecular weight heparin only advantage is single dose. It can be given subcutaneously, even at home you can give. Third one is there is no need of monitoring AETCM. Here you have to monitor all these things, but cost is very low. That is the main difference.
so then
If patient develops bleeding on heparin, what will do? Protamine. Okay, low molecular weight heparin, patient develops bleeding. Then also protamine can be tried. It cannot work like heparin. That's all.
So in due course of time, she was able to be extubated her properly. We successfully extubated her, then slowly initiated her on oral feeds. So we stopped the RT feeds, then mobilized the patient. So DVT prophylaxis also was taken care of, and then now into rehabilitation. Probably another day or two will discharge.
What else you want to add?
Basically, according to the newer guidelines, actually they said criteria like use of should not be used to rule out sepsis. So the patient coming with a history of like probable sepsis and all that, we have to try and start treatment immediately. So the initial plan will be fluid resuscitation with 30 ml per kg we can give, and before that we can also try fluid challenges like great partial like great test, and also even mini fluid challenge can be done if the patient is having continuous hemodynamic monitoring. So after that, we decide that the patient is actually in a probable case of sepsis with or without shock. So a patient with definite sepsis with shock, we have to immediately start antibiotic within 1 hour. But probable sepsis also with shock, we have to start within 1 hour. But a patient without shock, with the probability of sepsis, we can give within maximum 3 hours. That is the current guidelines. And also, if the patient is not improving with fluid resuscitation, we can immediately start on the first vasopressor as early as possible. And also, if you're not able to get a central line or any main lines, actually we can even start on peripheral lines. So the initial treatment can be started with a good peripheral line also, but start as early as possible. And if the requirement is going like between like intermediate or moderate or severe, we have to start a second vasopressor. So we can add vasopressor as a second line agent along with noradrenaline if the patient is not improving his MAP even after moderate to severe requirement of noradrenaline.
Which one you had?
This patient actually
second choice.
Second choice. And also this kind of patient vasopressin. And also this kind of patient.
There are two guidelines. One is if the patient is having tachycardia, your vasopressin is very good. Patient is having bradycardia, dopamine is a choice. If the patient is having cardiac failure, then dobutamine is a choice. So the general guidelines is that you start vasopressin.
So with noradrenaline vaso, patient is still not improving, we can also think about cardiac dysfunction. So once the BP is like above systolic, able to get 90 or something, 100 and all that, we can start dobutamine as a second line agent to improve to assess the cardiac dysfunction also in this kind of patients. And also as early as possible, this kind of patients will actually benefit from getting an arterial line for continuous hemodynamic monitoring also. And also lactate, actually the newer guidelines are actually giving controversial this thing because actually lactate, following up lactate is not just like it's not recommended as it's previously used to. So we have to think about all the multiple factors on following the improvement of the patient, like that.
Lactate alone is not because hypoxemia also can produce hyperlactemia.
So it alone cannot be used as a guiding factor for deciding on the patient.
Many drugs also can produce hyperlactemia due to mitochondrial dysfunction. So other factors should be checked.
Hmm.
Okay. Thank you.